Now, day 2 was the needling of the elbow and the thoracic drills. Day 1 was the evaluation. Day 3, what's going on? Elbow, so much better. Elbow, just perfect. It's almost like 100%. So we did shockwave, fenestration, dry needling, and some of these thoracic exercises. I'm like, you haven't golfed, have you? He's like, no. I'm like, keep it that way. Because we started to get into this understanding that that's gonna be the final piece. His sport at an elite level was lacrosse. I'm like, there's no way you're swinging ideal, especially when you have this incredible physical and emotional history of rotation with an implement that you can't really bring exclusively to the golf swing. So please, let's stay off golf. And he's like, well, I actually did three rounds where I drove, but it was a fine. I was like, great, perfect. We have a baseline. 3 is your limit. Don't do more than 3. At least you have a reason to believe that if you do 3 again, but nothing is scientific unless there's 2 times. 1 time of 3 is nothing but luck. I can't tell you that your elbow isn't gonna hurt or something else is gonna hurt. He's like, I was just excited. I'm like, good, be excited. You're not a bad person. But if we're really gonna get after this in a reasonable time frame, we have to try to compartmentalize, be an engineer, and understand that if we have to eliminate things, to make sure we understand what is going to be our best solution, what's the lowest hanging fruit. I cannot possibly expect a golf lesson to identify major issues if he's got all this pain everywhere. Like, is he swinging that way because of pain? Or does he always swing that way, which drives mechanical load, joint strain, and that leads to pain? I don't know any of those answers, and guess what? Neither do you. So now, day 3, which is where we're at, and I'll see him again, I believe, tomorrow at the time that we're filming it. So this is all I got. So now, it's like my neck is killing me. Like that, I think that's the worst of it. The elbows were there. I'm like, okay, so let's take a look at the neck. And you might have noticed the notes that I had that I showed him. That was based off our session 3. So here's what we got. Flexion, no big deal. Cervical extension was uncomfortable. We're in the cervical, okay? So he called that pain, all right? And then we looked at rotation to the left, and he had symptoms, pain on the left. When he went to the right, pain left. All right, now what does that tell us? That tells us that our probable intervention probably will be on the left side. In no way, shape, or form, nor did he want me to, were we going to manipulate. Not gonna happen. But if you close the joint, so in the camera that I'm seeing, I'm looking to the left and I feel left, I should probably be being pushed towards an initial treatment of the joint system, not the soft tissue. Yes, there are soft tissues that are stretching when we look left, but the first place that I would start to think of as my hands that are trilingual, you can go back to a video that I filmed probably a year ago when we were cooped up in that miserable hotel in Puerto Rico. Your hands need to speak 3 languages. If I'm touching him or in my head, what am I trying to accomplish? There's something, remember the facets in the cervical spine are kind of on top of each other like this. I think the issue is there because when he looks left, it doesn't go, and then he perceives something. Doesn't mean there's pathology, doesn't mean there's a disc, doesn't mean that there's a facet syndrome. All I know, and that's why I'm using happy faces and smiley faces. I'm not using commercial words like functional or whatever. He's got business on the left side of his neck. That's all we're gonna say. And that way, you have room for more techniques. You can do anything you want. Just make him look left and not feel left. I'm giving you my rationale for why I would start something on the left side. We did break down upper cervical and lower cervical, but it didn't tell us much. Like, it kept changing sides. And what you saw earlier is that, and I explained to him later in the session when we were done, when things change, like whether you're moving around throughout the day or things that don't necessarily make sense when we're doing our passive testing, local biomechanical testing at the cervical spine, of which there's probably not a significant amount of validity in the literature other than a side glide. If it's always changing, we probably shouldn't be as focused that this is a frank structural problem. If there's some kind of like the elbow issue where there's local inflammation and there's structural change at the tissue, it's going to be that way no matter what we do. If you change the environment, if you go active versus passive, all these different things, it'll relatively be the same. And his is all over the place. He's like, no, that one didn't hurt. That one hurts. It goes from right to left. We settled on this because it showed us where things, kind of gave us a funnel. At the end of the day, anything can solve anything with the sensitive nervous system, which is what this patient was demonstrating. So we basically need to treat the neck. And again, if this goes over, we needled away from where he had his primary symptoms. Again, that's always going to be an approach that I would take. I'm not going to jump right into the fire. I'm going to start to corral the fire. So we dry needled multifidus at 7-1 and at 6-7. Why? Well, at least at 6-7, I'm going to be having I could create some, help him create some variability at that joint segment, at that nerve root, which will then potentially modulate the noxious message of his elbow. Now, ideally, we need to go north. Well, we didn't go north yet. We just hit those two spots, and it actually wasn't this enormous change that you often see. So I did not expect that to have a direct link here. I did expect his cervical spine to move better, move more, and it didn't really do that. So what do we do next? Well, I know I have done something at those levels of C7-1, C6-7, okay? So I treated those two spots, and so now, if I have an opportunity at a rehabilitation, a very, very low level, then what am I going to do next? I'm going to go to an Eldoa that'll follow up here, where if anything, that links therapy that you think you're addressing the joint, and then an exercise where you think you're addressing that joint but not another, the Eldoa is a very rational decision. I tend to think, in my experience, when you use Eldoa, the way I'm describing it, probably not the way, the first time I ever learned it, I messaged Sam, I'm like, what is this? Like, I'm supposed to do every segment every day? Like, that you're just assuming that these things are problems. He goes, yeah, that's osteopathics. Well, that's not how we're dealing with this. We're gonna use these tools that are purported to create modulation at a particular segment through this mechanical decoaptation, this traction, this decompression of the nerve root. So we went to, and we worked at it, because these are kind of esoteric positions. I will demonstrate them in future videos for the purposes of further illustrating this treatment process. We did 7-1 instead of 6-7, because I didn't want his shoulders to have to be active in an elevated, it's not an elevated position, because in 7-1 and in T1, T2, the arms are overhead, but they're on the ground. So you're still going to be active with external rotation, but he didn't have to hold them up. And then because of his posture that was a little bit kyphotic, we gave him an Airex pad in the top of his neck. You'll see that in DNS patterns also, because DNS and Eldoa are like, the positions are strikingly similar, and clearly the value for a centrated neutral spine, same thing. It's like, oh, that looks just like this pattern. So there's a reason that they're both very, very powerful osteopathic for musculoskeletal treatments. Now, coached it up, chin in, eyes down, heavy Eldoa arms, and then every time he got up, his neck moved more. And I said, look, this is where we're going. Like, these are going to be your homework. We gave him two Eldoa positions. Even though it wasn't where we needled, we gave T1, 2, this is T, and that's where we left it. Checked in the next day. He's like, yeah, it wasn't moving as well as where we were, but it's definitely better. So I'll see him again tomorrow. We'll see where this lands. So I've seen him for 3 days. His homework after this was not to test all the time, but to certainly build up to 1 minute with these patterns. And I because he's a hard driver, I'm like, yeah, ideally let's start with less. But if you want to do 1 an hour and your neck moves better, how do you know that it moves better? Look left, you don't feel left. I'm not even worried if you feel right. Look right. You just feel stretch. You don't feel pain. Look backwards, and you don't have any symptoms in that same area. So I believe that there's clearly something on that left side. I probably was too conservative with the location of the needles. I probably should have gone a little bit more north and have a direct impact on 5 and 6. Of the cervical spine, and then continue to open up this package. Now, the other thing that we're going to get after in the next session that I thought of out loud before we put this video together, we also need to look at median nerve. If we're talking about the neck and we're talking about these patterns, we need to clear that we need to clear that as well, because to suggest that it's not multiple ideologies that could be contributing, and at the end of the day, if all you're doing is moving and all of a sudden the symptoms are better, that might separate me from an ardent evidence-based approach. I don't care. Yes, no question, I am probably going to try to attempt to tension or slide the median nerve. But if that's not what's happening, if we actually put him into a fluoroscope, or I can't prove it, what I can prove is going back to day 1, and does his elbow hurt less in what we probably do agree upon? And does his neck move at a more acceptable range of motion? Does his shoulder have less symptoms when he does normal movements in his training with Brendan? I don't necessarily need to have that level, because it's so easy to say this is Eldoa doesn't do what it says it does. Well, I don't care if it does or doesn't. I can prove why I'm doing it, what I learned, and what I am trying to test on my own, and I can prove if this other level of movement or symptoms that has nothing to do with the intervention. And that's one of the most important things that I really try to put together when I try to talk through the evaluation and the treatment process. You can only prove 2 things. You can prove what you tried to do. You can't prove that it actually happened. You can prove what you think you're doing. You can prove that, okay, my hands are here and I think I'm on the subscapularis and I think I'm breaking capillaries and increasing blood flow. And I think as a result of that blood flow, the energy crisis theory concepts are going to temporarily change that tissue and then potentially change what we might see as a trigger point referral. I can't prove that that's happening in my setting, and I don't really care. What I do care is that does this change? And then if it does, let's get into training the connective tissue. Let's get into training the humoral and hormonal effects, and let's get strong. I mean, that's really, like, if you have no pain and you have relevant joint competency to do other things, it shouldn't matter, like, well, you're not allowed to do that, or that's not what happened. Really? Does his elbow not hurt anymore? Does his neck not move to 95 degrees now, even though it didn't before? That's the standards that we use. You can't prove anything other than what you try to do and if the individual is happy. That's the game plan. And if we do an adjunct to this one or future case studies, I'll show you where to needle here. I'll show you how to needle there. I'll show you the soft tissue stuff we did. We'll go over the thoracic and the Eldoa and any other exercises, and then we'll take a window into how we can get this fellow into training as aggressively as possible at the same time. There is no handoff. There is no pass off to strength and conditioning or fitness. We're doing them both at the same time. And if your patient doesn't want to do that, then you're not going to get to the result as quickly as if you did, because then you're telling me that things like hormonal factors have nothing to do with tissue healing. I'm pretty sure they do. I don't know why we wouldn't be looking at that fitness approach while we look at the rehab approach. So that makes it very challenging. I mentioned that call with the NFL player that I had yesterday. I don't think they understood that, which can make this thought process very threatening. Where, well, I'm just about done with physical therapy, but I know you're a physical therapist, so I know you. I'm like, yo, it's all the same, man. Like, I don't know. So I hope this makes sense. Let's get some feedback in terms of if this is useful. I certainly hope it is. I think it will be. But then we'll have adjunct exercises and demonstrating how to do these things within this context. And then what I foresee is having a catalog or a library of the exercises so that when you need them, you can go back into and see the title of those exercises, which will be separate videos than the narrative stuff that we did here. So one last thing, when we're at the whiteboard, we have this good opportunity. If you find this individual, often seen in the Crichton section of Mobile, Alabama, if you shine a light on it, sometimes he disappears. But if anybody's seen the leprechaun, say, yeah,